You will use the microphone, Mona. Microphone. Handle. Don't- But I will prepare only. Sound check this. Just wait. I will. It is correct.
Oh, yes.
It's correct. This one.
But we need to hide this a little bit. Can you turn it up?
Just call me.
Okay, thank you. Suddenly it stopped working.
No, because the settings on the computer, I found it that PC only. This one Windows P. Before it's PC screen only. That's why there's no projector.
Okay,
I
so I
put on
should
duplicate.
duplicate.
Yes,
Windows.
Windows P. Both together.
Okay.
Windows then P.
Yeah. Okay.
Okay.
Thank you.
Okay, no problem. But now it's okay. It's set up for duplicate.
So it shouldn't
No.
it should be working all the time.
Yes. Yes.
There is no time.
No.
Okay.
But can you check your next? You have a presentation another. Can you check if
It's on the
same
desktop.
the desktop?
Yeah.
And check.
So our presentation.
Only one.
So I should
There is
press
more. There is
exit.
more.
Yes, on the
Here?
desktop.
Where
Yeah,
is that?
it's all of them.
All of them.
Yeah.
Okay. Okay. You just click this one.
Yeah.
Then share only like this.
Okay. Okay.
See?
Tamam.
You need to log in, ma'am. Wait, you need to log in because
Maybe it
yeah, you need to log
went
in.
signed out. Thank you.
Yeah.
Because I
Pag,
logged.
on this one, ma'am, see, you see the screen is not fit on the screen because there's a display setting for duplicate as well, like this, duplicate. If you duplicate, the screen is will be fit like that.
So now it's only that because this is the only one shown.
No, which one the person?
interested in the this is part of طلب العلم Islam. Maybe just to make sure that everything.
Yes, sure, sure.
today to our second book launch for this semester. The book that we are like celebrating and taking as a point of departure for our discussion today is published by Dr. Minaretein under the title of Islamic Ethics and Incidental Findings, Genomics, Morality Beyond the Secular Paradigm. So this seminar brings together experts who will explore one of the most complex ethical challenges in genetics and genomics, namely the management of incidental findings, unplanned discoveries that emerge during genetic testing and biomedical research. So 3 speakers will examine these ethical challenges from diverse angles, namely biomedical, clinical, and Islamic perspective. This seminar is an accredited group learning activity, category 1, as defined by the Ministry of Public Health, Department of Healthcare Professions, accreditation section, and is approved by a maximum of 2 hours. The proceedings will start with Dr. Minaretein, who will talk about, he will introduce this seminar for 10 minutes, and then we will, proceed with our guests one by one. So, Dr. Ghali, the floor is yours. Please go ahead.
Thank you so much, Dr. Sami Rashwani. Dr. Sami Rashwani had a book launch for his own book last week. So he is in the mood of books, and it's true. I recently published my book on this topic, but of course, today we are not speaking about the book in particular. We are speaking about the topic. The hero here is the topic, the ethical management of incidental findings from the 3 perspectives, the biomedical, clinical, and ethical ones. Very happy to have 3 prominent colleagues who have been working, engaging, and to a certain extent struggling with these secondary and incidental findings related to genomics. Dr. Saeed Ismail, Acting President and Chief Scientific and Operations Officer in the QPHI, Qatar Precision Health Institute. Dr. Professor Tawfiq bin Amran, Division Chief of Genetics and Genomics at Sidra, and Dr. Amal Rubai, Assistant Dean of the Office of Research Compliance at Weill Cornell in Qatar, and myself. I would like to start by some introductory remarks before giving the floor to our speakers today. There is one thing that I shouldn't do, and I will not fall into this mistake, that's introducing what incidental and secondary findings from a scientific perspective. So I will leave this to my colleagues, because I also want to learn more about this. But in my introductory presentation, I will try to explain in simple words for people like myself with my background about the question of genetics and genomics in general, and how the scientific advancements are also creating ethical questions and challenges for people in the field of ethics and bioethics in particular, so that we can pave the way for the discussions that happen. So if we can go to the next slide. This one. Thank you. So I don't have any objections. This is the quick outline. Yes. Just to give you a background, this is usually how scientists and physicians used to look at the human body. So it's a hardware thing. It's a physical body with organs. These organs we could have access to, the inside ones, only after death through dissection. By time we could have access to them during life through X-rays and so on. But it remained always like something physical, something hardware that we look at. If there is a disease, we try to check these organs that something maybe is going wrong, maybe give a medicine or a surgery in order to fix the problem. But something happened in the second half of the 20th century that made a big change for biomedical sciences, which we started to look at the human body this way. We started to look at the human body in a digital way. It's not anymore the hardware version, but the software one, which is a composition of ACTGs. Yes, there are billions of letters, so many, with repetitions. This shift was not only a biomedical one, but more importantly, an ethical one. So you may think, okay, ACTGs will help us understanding the underlying genetic cause of the disease that we have, and that's how we can understand diseases, the etiology of diseases in a much better way than before, and so on. But it doesn't stop there. So we started to ask ourselves, when we have and when we discover the gene mutation, or as we call it nowadays, a variation, and in a more neutral way, when we discover this, is this a disease or not, in itself, by itself? Are we going to define what sickness is, redefine what sickness is? So if I have a gene with this mutation or this variation, and I don't have any symptomatic diseases, am I sick? We have now the premarital genetic testing. When we have negative advice for the marriage, does this mean one of the couple is sick? Are we going to approach it this way? So we started to have questions, redefining what is health and what is sickness. And by time, we started to ask questions about what is human nature? What is our nature? Are we anything beyond the ACTGs in our genome? And we started to have discussions about the so-called genetic reductionism, those who try to reduce human nature only to the genome and the ACTGs, or even only the genes that we have, became a big question. I have here my students who are attending the course on Islamic bioethics, so they know these things. So sorry if I'm repeating what you heard before, but we can get into further details. But for now, I'm just trying to say that this discovery was not only a biomedical shift, it was an ethical challenge. And moral philosophers, not only within the Islamic tradition, but beyond, have been grappling with these important questions. We also had genetic determinism, not only genetic reductionism. So some scientists, even big scientists like James Watson and Francis Crick, they have statements that can be easily read as reflecting genetic determinism, and that we don't have free will, and everything is hardwired into our genomes, not only our health and sickness, but even our morality, our ancestors, what kind of children we are going to have. Everything is written and hardwired in our genome. This is not a scientific issue only, it's also an ethical one. So we started to look at the ACTGs as a book of life, not only a matter of health and sickness, but a matter of life, through which we can know more about our past. We have the DNA ancestry, that we can go back in our history in order to know not only our genetic parents, but grandparents to thousands of years before. We can think about now, and we can also think about the future. People who are born, once we sequence their genomes, we can know their susceptibility to specific genetic conditions. Once they are born, and sometimes even before, like the premarital genetic testing and so on. So we started to have too much information. And too much new information that we didn't know before when we discovered this digital version of our human body. And the big question for this information, how to manage them. Okay, this new information, not only how to interpret them in order to know which ones are clinically relevant or not clinically relevant, but also which ones are is justified from an ethical perspective to disclose, not to disclose, and so on. And here comes the topic of our seminar today, the ethical management of incidental findings. The more common term now is secondary findings, because they are not incidental anymore. We know that they are coming. Once we go through this book of life, we know that we will come across findings that we didn't plan when we ordered the genetic testing or when we started the genome sequencing, for instance, Qatar Genome or Qatar Biobank. So these scientists or clinicians, while they are using this way of reading the book of life in order to get more information about a specific health condition, they will come across things that they didn't plan for before. So I want to know the genetic condition behind the disease of child X. That's the plan. But while I'm turning over the pages of this book of life, I will incidentally come across findings that I didn't plan, that this patient and his or her family did not plan, and that the research participant didn't plan, that the researchers didn't plan. And this information is a lot, is not of one type. To judge, let's do this or not do that. They are not only about clinical findings or health-related findings, but sometimes about non-clinical, like lineage, far or distant, or near lineage, paternity, maternity, and so on. What to do with this? This is, as we shall say today, is not only scientific or biomedical or research issue, but it is also an ethical issue. I personally started thinking about these questions and receiving them once I arrived to Qatar. I came to Qatar by the end of 2013. The first question I had on my table when I started my work as professor of Islam and biomedical ethics was about genomics. The colleagues in Qatar Genome, they contacted me. They said, we want to know what Islam says about this. Of course, I appreciated very much their interest in knowing about Islam, but I said, I also do not know how to do these things. So we need to navigate through these questions together. So there was a long journey, more than a decade, exploring these questions, struggling together in order to find answers. Sometimes we agree, other times we disagree, but we all agree that what we are doing shouldn't be only scientifically valid, but ethically sound. So the end of this journey, I mean, the last chapter of this journey, it hasn't ended yet, was this book that Dr. Samer mentioned, which is, I would say, a collective effort. It's not only my work, but the work of the colleagues, especially in the other side of my research, the scientists and the clinicians who brought my attention to this book. I'll talk more about this when my turn come to my presentation. Now I'll give the floor to the speakers.
Okay, thank you. Thank you very much, Dr. Ghali, for this introduction. Our first speaker today is Dr. Saeed Ismail, who is acting President and Chief Scientific and Operations Officer at Qatar Precision Health Institute. The title of his presentation is Big Data and Incidental Findings. Dr. Saeed, the floor is yours.
Thank you very much. شكرا جزيلا على الدعوة. It's always a pleasure to be with you, Dr. Ali, and the esteemed speakers here to talk about this very important aspect of our work. It's not secondary ethics to our work. It's at the heart of what we do, definitely. And we are blessed to have Dr. Ghali with us here. And I'm not exaggerating if I say that this interaction between a distinguished bioethicist and a large-scale genome project is leading the way or paving the way, not only in Qatar, but regionally and maybe for the whole Islamic world. What is included in that book and the other publications or conference papers is very likely in so many cases is first of its kind to be written and made public. And as we say when we interact with Dr. Ghali, there is a lot for us to learn, not only us in the region, in this culture, but also globally. And I always remember when we were interacting with our colleagues from Genomics England, and they were talking to Dr. Ghali, and they just immediately invited him to go to talk to their bioethicist back in England, because there is plenty of interesting stuff that we brought here that could be of relevance to them there. So I will now go through my slides very quickly. So I have, this is to the close, and that's the main objective, is to tell you, assess the significance of returning incidental findings from big data. Our case is as complex as it gets, as a large scale genome or biobanking program. We're not talking about a patient and a test, and then there was a secondary finding or an incidental findings. We're talking about a national project with tens of thousands of participants. That's the first complex factor. The other one is that we're doing whole genome sequencing. So many people are involved, and it's whole genome sequencing. It's the whole book. It's not a paper or a chapter. We're writing or developing the whole genome sequencing for it. So there's plenty of data belonging to plenty of individuals. So more or less the cause of the bioethics will be the same, but it's at scale. So these large-scale genome projects, as I was talking to our colleague once said, they're budding like yeast. They started in few countries, and Qatar was one of those few countries. I'll tell you in a minute who they were, but they keep budding all around the world. And this is an old slide. So there is more countries producing such large-scale genomic data for a large percentage of their population. And so what we will discuss here, again, will resonate in other places around the world. It all started in a place called Iceland. That's a very small island on the north of the Atlantic Ocean by Carrie Stevenson, a pioneer. Actually, they started 15 years before everybody else. Small country, small population, with an interest suddenly in genetics to trace their ancestries, but then of course it developed into a full-fledged medical or biomedical project, and then the whole world was watching. In 2014, 2015, suddenly all these programs started to bud. Genomics England, the All of Us American program, 2014, 2015, around the same time, that first wave of national project, the Genome Project, the Biobank was even there before a couple of years, 2012. So Qatar was among those first few nations to launch their own national programs, and then face these ethical questions at scale again. So why then? It's not now. Why then? Why in 2015, 2016, everybody else was thinking about launching their own genome projects? It's because of the unprecedented evolution of the sequencing technology. I'm just putting some examples here. Sequencing the first genome when the presidents of our Prime Minister of the UK and the President of the US went live to announce the first genome genome draft in 2001. It took them 10 years and around $10 billion to sequence that first genome. Now you can sequence a whole genome in 10 hours, maybe under soon, and for a fraction, from 10 billion, or let's say billions of dollars, to now at the mark of $200 per genome. $200-300 you can do a whole genome. And the other thing is that suddenly you have an expansion of the amount of data. So we're not talking about genetics, we're talking about genomics, which is a lot of genetic data, basically. In every single presentation of these large scale genome projects, you will find this slide. This slide talks about Moore's law. Basically, I'm not an economist, but if you have a new technology, then you expect the technology, the price or the cost of technology to drop according to Moore's law. Sequencing technology is one of those cases where it defied Moore's law, and it went very quickly and very sharply. So it became so affordable that people now can do a whole genome. If you say $200-300, just a few years back, if you go and do one single genetic test, Dr. Amran bin Amran will tell you that it could cost the same. I mean, some genetic tests would cost $200-300 easily. So the technology, this is to show you where we're heading from. The first genome took maybe hundreds of those washing machine size Sanger sequencers to sequence one genome. Now we're talking about a handheld device, this nanopore, that can do whole genome sequencing. So technology is evolving at an unprecedented rate that will make a lot of data available. But it is a lot of data. Look at all, I mean, this is one genome. All these volumes, this guys just cleverly show you the amount of data, the 3 billion letters in one genome, and that tells you that it's even more complex. It's not just the technology that will enable you to produce this data, it's making sense of it, the interpretation of it. And here comes a new whole area of science called bioinformatics, where IT meets biology and people can manage this big data, and it is big data. And to make it even more complex, it's not just genomics. So we will focus today on genomics, but now we know we're heading to the multi-omics world, where you get information about the genetic component or content of the cell or the body, but also the proteins that are there, the RNA molecules that are expressed, the metabolomics and the epigenomics, and so many other omics. So it's adding more layers of complexity that, as we sometimes say, if we stop generating data now, everybody around the world, I think will take us maybe 5-10 years to digest the data we produced just now. And if we stop in 5 years, it will take us maybe more. But we are lucky now that AI is here, computing power, those HPCs are also evolving to digest this huge amount of data. So we at the Qatar Precision Health Institute, as you see from the logo, we're basically the merger of Qatar Biobank and Qatar Genome. We hold one of the largest, we work with everybody in Qatar here, but we have so far sequenced 45,000+ whole genomes. And what we do here, I think, is really unique when you consider not even the region, but the whole world, because it's a small country with a large representation of its population. So you can translate research into implementation practices that even the most advanced countries cannot even contemplate because of size. I mean, in the US, if they do 1,000 whole genomes, it's way difficult for a healthcare system that is fragmented and for a huge country to move into implementation as Qatar would do, or Iceland or Estonia, those small countries with large scale genome and biobanking projects. These are some of the multi-omics we are expanding on. So bear in mind, again, it's not just whole genome sequencing, it's a lot of data, a lot of those multi-omics data, plus the very rich phenotypic data collected at the biobank for each participant, plus access to EMR data. So it is, I cannot just say, a lot of big data that we have produced on behalf of Qatar, and indeed on behalf of the whole region, because this whole region was very much underrepresented in the international databases. 400-500 million Arabs are largely underrepresented in the scientific literature internationally. And so whatever we do here, even if we focus on Qataris, will resonate more to that larger part of the world. And we've also, by the way, sequenced thousands and thousands of long-term residents of Arab ancestry. So we do represent this part of the world genetically, and we hope we can also lead the way ethically to sort of help not only the local community, but also the whole region at large. And this was recognized in top journals that what is happening in Qatar is actually representing doing a great job in increasing the diversity of genomic data. This Nature paper was celebrating 20 years from the first whole genome sequence that I mentioned in 2001. And you can see that first wave of programs, Genome Denmark, Genomics England, all of us in the USA, and then Qatar Genome, Australian Genomics. What happened here and still is at the cutting edge. And we produce the vast majority. This is another paper that confirms what I've just said. Most of the genomic data representing this part of the world comes from Qatar. Okay, so I've just now mentioned, I've showed you how big is the data and how big is the challenge. Now I'll tell you that when we were launched, we have had this, we call it 7 pillars strategy or national strategy built on 7 pillars. One of them is policies, regulations, and ethics. So we knew very early on that we have to prepare the scene in terms of the ethics, the policies, and regulations, because this is a new territory for all of us. So we're lucky again to have Dr. Ghali and others here to help us again prepare. These are some of the documents that were produced by us or by our partners, whether it's SWISH, whether it's MOPH, whether it's Dr. Barry at the College of Law. So we're lucky again to be in that position, able not only to produce data, but to sort of produce these founding literature paper that will help people move on. Our researchers, in the next few slides, I'll show you that our researchers are mining the data and producing a lot of useful results. We have actually involved every single research institute in Qatar and every single researcher, biomedical researcher in Qatar. You'll find him here or there. A lot of very interesting papers was produced telling us a lot about the genetic makeup. This, for example, paper or a series of paper on the ACMG, American College of Medical Genetics. This is one of the most important bodies around the world that tells you about this mutation, where it's actionable, where we can do things about. And we knew, for example, from the last one, that over 3% of the Qatari population are carriers of one of those mutations. So it's a very useful piece of information. Dr. Lutfi and Dr. Saad and other colleagues produced this wonderful paper telling us about the variants causing familial forms of cancer in the Qatari population. So we can now design, and I'll tell you about the very interesting, in the last slide, story stemming from that paper, how we use this information from research to design a preventive program or reductive genomics program. Another paper by Jitesh on the pharmacogenomics landscape, another paper by Khalid on the Mendelian disorders burden. So what I'm trying to here, the first paper by Dr. Saad and Dr. Swedi on polygenic risk scores related to heart disease. What I'm trying to tell you here is that even with COVID, we produced the data and we have now came up with the conclusions that could be translated into medical practice. Okay, so this is why QPHI was created. We've produced enough data. We've digested that by the researchers, and now we are able to translate that into clinical actions or clinical practices that could touch the patient's lives. And so we started some clinical pilots, whether it's pharmacogenomics related to statins, clopidogrel, warfarin, breast cancer, and other wellness genomic reports. So the array that we produced as well. That brought us now to the issue became more imminent. Now we have to face that. And actually, just before that, we've had a very interesting meeting with both colleagues involved, Dr. Ghali and Dr. Ben Amran, about what I'm just describing. We have a lot of data. We've sort of identified those variants that could be relevant to the public health, and we are now about to do something about it, because again, this conversation that I've had with Dr. Ghali many years ago that I keep bringing up is that when he said that if it's life-threatening, if it's actionable, then you have to report on it, when we were just starting our own program. And again, that example that if you are making wudu or praying and then there's someone drowning next to you, then you have to break it and go and save his life. And he didn't care much about what our consent says. If our consent says that you give your sample, we do the whole genome sequence, this is for research purpose. We're not obliged to give back any genomic data back to you. And he said, بديش أقول الكلمة بالعربي بالوشم ميته بس it doesn't really matter. There's something that is more important. So we went back and changed our consent to enable us to be able to give back return genetic data to our participants. And of course, we spoke to the bioethicists, but we spoke to the clinicians. The clinicians had another thing. I mean, we're blessed again to have Dr. Ben Amran, who's always willing to listen to us and help us design these studies. Others were maybe, please don't overwhelm me with all these referrals that will result, because you know a lot about a lot of people, a lot of genetics about a lot of people. So we've had to carefully prioritize which pilots and which programs, which projects to launch by consulting the clinicians and the bioethicists. So before I finish, I'll just go very quickly through the final set of slides, and you know what incidental or secondary findings are. They're way more complex than leaving a scissors in after a surgery as it used to be, and then you go for an X-ray and you discover that the surgeon left something there. It's way more complex, and there's so many questions that you have to ask. And for those who are non-experts, I mean, what we mean by actionable, non-actionable. So I know a lot about your genome, but if I tell you you carry that mutation or that variant, and there is something you can do to prevent the harm, then I have to tell you something. What if I don't? What if the clinicians or the clinical system doesn't offer a solution? Or you carry a mutation, for example, just a rough example, that you're very likely predisposed to Alzheimer's. Shall I tell you? Because there's nothing you can do. You can try to memorize things, you can do things, but there isn't a very effective prevention or preventive program or drug or whatever to prevent what you're predisposed to. Should I tell you still, and you bear the responsibility, or should I not tell you? The mutations we talk about, variants, it's never as clear cut as you would think. And these are the 5 main classifications we in our business. So a variant is benign. It's different from others, but doesn't cause disease. It's likely benign. We think it's there, but we're not 100% sure. And then those in the middle who are of unknown significance, we still have to do more work to classify them. Then there's the likely pathogenic and the pathogenic. The summary of the slide is basically there are millions of variants or mutations that we do not yet associate to a certain disease or treatment or preventive measure. So there is a lot of research still has to be done. And I'll give you one story to show you even how difficult it is. There was a very famous story of 2 parents who had a child, and then the parents were told that he is carrying, they lost the first child due to some sudden arrest. And they were told that your next child, your second child, is also carrying the mutation that caused the first child to die. So as a prevention, you can put a pacemaker based on a paper published in one of the most prestigious journals ever by leading groups around in top institutes. They go for the second child, they do the procedure, they put the pacemaker. Then later on, another paper contradicts that one and said it's not really related. That it's too late for them to go back. So even science at the highest level can sometimes change. This is why we go back to clinicians and say, out of this haystack, which needles to choose to put in those programs that will enable us to return genetic results, because we are obliged to do so. And then there's another complicating question. There's so many aspects to this, and Dr. Ali is more aware of those. The right to know and the right not to know. If I suddenly start to give back a lot of genetic information to a lot of people, and then is it my right, my duty, my obligation to tell him? What if he doesn't want to know? Is it his right or mine? Whose right is it? There's plenty of literature here, and there's a very famous international study about your DNA, your say. I mean, and it's an ongoing discussion. And this is why each group of people, each society, each culture, each country should decide for itself. There are no clear-cut answers for these questions that everyone around the world should agree on. So this is why what we're doing here is so important. And I'll end with this very positive example stemming again from that discussion we had many years ago. And we decided to, yes, we'll change our consent, we'll return genetic results. Let's choose the best example, the best pilot. And of course, it was BRCA1 and 2. These are two genes where variants in those genes are very well known. Science is established, solid, khalas, they will cause early onset or familial forms of breast cancer. So let's start by those and see who in our own cohort at the biobank are carriers, call them back, refer them to the clinical pathways, and engage them in preventive programs. The pilot was very successful. It wasn't easy, but all the efforts and all the discussions, the extensive discussions that happened here about how to change the consent, what exactly to tell him in the first call, how to counsel him when he comes, before he does the secondary or the second confirmatory test, how to triage him through the healthcare system. We've built a referral pathway from a large scale genome project to the healthcare system. The success of that program is what led us now to expand, inshallah, to the whole ECMG, is what led us to have our meeting early on today with Dr. Tawfiq and Dr. Ghali and others from Hamad and other places to tell them about our ideas. It's just a brainstorming session, but we were encouraged to move on because we've done it with this very interesting pilot on familial forms of breast cancer that started from a conversation with a bioethicist and not a geneticist. Thank you very much.
Thank you very much, Dr. Saeed. Our next speaker is Dr. Tawfiq bin Amran, who is Division Chief of Genetics and Genomic Medicine at Sidra Medicine. He's going to tell us about the clinical genomic dilemmas. So the floor is yours, please.
I can move with this one. They will take this because I was sitting the whole day. I need to stand a little bit, so. It's working.
في لايف ستريمينج وصوتك ما راح يطلع.
والله.
يعني ممكن شيء المايك هذا بس لا. وهذا اللي راح اشغله شيء.
شكرا الله يعطيك العافية. بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. So I would like to thank Dr. Ghali for the kind invitation and also to thank Dr. Saeed for setting the stage. So please, if you have any questions, you can ask Dr. Saeed. Don't ask
He's
me.
the clinician, I'm a scientist.
Okay, so I would be mainly presenting cases like real cases, and we will talk mainly about the role of genetic counseling when you have secondary or incidental findings. So already Dr. Saeed mentioned about incidental, or now we prefer to call it secondary findings, because actually we are looking for in a certain set of genes, and we have currently, according to the latest American College of Medical Genetics, a list of genes that, of course, when we do whole exome or whole genome sequencing for a patient or a family, we provide a pre-test genetic counseling, and with a consent, either the family can opt in or opt out for about 73 actionable genes, and already we will have some examples about this. Again, just I would like to highlight again about the important role of pre-test genetic counseling, because this is very important. You sit with the family, or for example with the patient himself or herself, explain about the genetic test, and important also to explain and discuss in details about the the possibility of discovering a secondary or incidental findings. So what we mean by secondary or incidental findings, for example, you have a child in front of you in your clinic, or you have an adult, for example, coming for a different disease or a different presentation. Let's say you have a child with developmental delay or learning difficulties, and you do the whole exome or whole genome sequencing to try and find an underlying etiology or underlying cause for this child presentation, and you end up with a different results completely unrelated to the primary reason for doing. So for example, you may find a hereditary cancer gene, or for example, heart genes or cardiomyopathy. So this is what we mean by secondary or incidental findings. And of course, there is a set of criteria already. For example, Dr. Saeed mentions that these genes that we included in the secondary findings, it's an actionable, means there is something to do, either treatment or prevention. And other criteria has to be severe, and discovering this disease or this gene early can make a difference. So for example, if a gene that there is no time or a specific window for a treatment, why you include it, right? So discovering this gene or this finding early make a difference. And already I mentioned, so according to the latest ACMG, there is about 73 genes, and all these genes in these categories, for example, cancer gene, familial adenomatous polyposis or Lynch syndrome, cardiovascular genes like long acute syndrome or hypertrophic cardiomyopathies, some inborn error of metabolism, for example, like Bombay disease, biotinidase deficiency, Fabry, and other miscellaneous diseases like malignant hyperthermia and Wilson disease. So discovering this, of course, always there is a group meeting, either including or discussing other genes to be included, and according to the set criteria. And already I mentioned this, so discovering this early make a difference. So it's actionable, it's severe. Bintrust is very important. You don't want to include a gene that you don't know. What is the bintrust, might not happen. And this is, kind of criteria for the disorders usually not to include it. If, of course, diagnosed clinically, already I mentioned this, the timing of diagnosis is not critical, or, for example, include only a lifestyle change. Now we'll go over a few cases just to give you more idea. So now I will ask you questions. Any doctors here? Hmm? I'm the only doctor. Okay, so I'll ask you a question. Okay, so this is case one. This is goes back to July 2020. This is a newborn baby girl with abnormal newborn screening, and maybe you will ask, what is the newborn screening here? So as you can see, I'm sure you're all familiar with this graph. So as you can see here, I don't know. So here there is low free carnitine, and this is we included in the newborn screening, in the national newborn screening, and this can give you an idea that this newborn might have a systemic or primary carnitine deficiency. And as you can see, even in the repeated, the free carnitine, which is very important for energy production, initial result was 2.5 and the successive result 3.6, and the reference range start from 8 to 72. So now there is a suspicion of primary carnitine deficiency. So this was an IVF pregnancy, normal vaginal delivery, no NICU admission, basically a healthy newborn. But when, like in genetic, the most important thing to take a detailed family history, at least a 3-generation family history. And when we sit with the family and meet the family, we took a detailed family history. And anything important the family history now? Other than the mother, so this is our baby in red. Other than the mother born to a consanguineous parents, and there is a brother or maternal sibling who died. We don't know what was the cause of death. Then we asked more, and this is the interesting part here. The mother has some medical problems. So she is 32 years when we met her, and she had this chronic history or long history of a chronic vertigo and headache. Also, she had some developmental delay early, and she had a recurrent episode of vertigo, vomiting, nausea, headache, and poor coordinations. Also, when we take a diet history, she's avoiding meat, chicken, so it's mainly vegetarian, you can say, and she has also frequent emergency visits. She had an MRI. When we look to the records, she had bilateral cerebral white matter changes, so a lot of workup done, but no diagnosis. So giving this newborn screening and this complicated family history, we decided to do whole exome sequence. This is not our way, when we have abnormal newborn screening, but because of this background, we decided to do whole exome sequencing for the newborn. And as you can see, the newborn was heterozygous only for a glutaric aciduria gene. So this is an inborn of metabolism. But the family consented for ACMG secondary finding, and we found the baby carry 2 heterozygous pathogenic variant, one in BRCA2 gene and one in the long QT syndrome gene. So this is completely unrelated to either the mother history or the newborn screening. So this was, creating a lot of challenges and a lot of discussion, especially with the grandmother. After that, she didn't like us anymore. But at the end, we found that the mother is homozygous and she has a glutaric aciduria. So you can imagine, the long diagnostic odyssey. This is second case. It's a 5-month-old boy premature birth and has some hormonal problem. Again, we did whole exome sequencing to find the cause for this hormonal excess, but again we found a secondary finding in the KCNQ1, and this is, as you may know, related to long QT syndrome. So knowing this is, you can provide treatment, you can provide preventive measures, and also you can screen other family members may benefit from this. Case 3, again, 6-month-old male baby with multiple MRI brain abnormality. So this is the main reason why we did whole exome sequencing, and the family again consented for secondary findings, and we found the baby carrier for or carry PRCA1 mutation, and as you know, this is cause hereditary breast and ovarian cancer, but for males is more important for prostate cancer. And again here you can provide a preventive measures, either early screening, provide preventive surgeries, medications, and other preventive measures. Case 4 is a 13 years old, again, boy. I don't know why I put all boys here. Child with cholestasis and other hepatic abnormalities. Again, we did exome sequencing to find out the underlying causes for the liver abnormality, but the family again consented and opt in for secondary findings, and we find likely pathogenic mutation in the TNNT2 gene, and this is related or associated with familial cardiomyopathy. So again, knowing this is very important, so you do frequent cardiology monitoring appointment. Maybe you can give medication or defibrillators, so a lot of things you can do. Again, I would like just to highlight about pre-test counseling is very important. You know, it's not just a blood test. When you do exome sequencing or genome sequencing, you need to sit with the family and discuss into details, and again, provide pre-test counseling about the possibility of finding secondary or incidental findings. In our society and in our culture, in most of the, the Middle Eastern or Arab culture, this is not only, a medical result, but also it's a cultural and social. One of the important things we face when it comes to more specifically to secondary finding is non-disclosure. So, for example, you find it in a brother, the brother will refuse to disclose this to at-risk family members. We find it in a sister and so on, So, for example, even we have one family that the parents, they want different appointment for their, they don't want the siblings, they know about the diagnosis. Also, for example, hiding result from future spouse. And we have this. So this is our challenges and our also social stigma challenges. And thank you very much.
Thank you very much, Dr. Tawfiq. Our third speaker is Dr. Amal Rubai, Assistant Dean of the Office of Research Compliance at World Cornell Qatar. She's going to talk about the ethical and IRT considerations. Dr. Amal, the floor is yours.
Hi, assalamu alaikum. Can you hear me from here?
Press the,
Oh, yeah, better. Well, thank you, Dr. Ghali, for inviting me today and for allowing me to be part of the discussion around a very interesting hard topic, which is incidental funding, especially when it comes to research. My background, I'm Assistant Dean of Research Compliance, but I also have actually a faculty appointment, and I'm a researcher myself in the field of genetics and pharmacogenomics. So incidental funding is something that I deal with both as a researcher, but also in my capacity as the head of compliance and IRB. I have no conflicts of interest to disclose today, and so in the next 20-25 minutes, we'll go through the ethical consideration and complications when dealing with incidental funding, mainly in the research setting, because I think my colleagues have plenty covered the clinical side. And I'll very briefly, I will go through an overview of the international recommendation on reporting incidental funding, and the last part of the presentation will be to identify the IRB review requirements and consideration for returning incidental funding. I'm assuming everybody knows what an IRB is. Okay. For the one who don't, an IRB is the institutional review board that is mandated to review and approve all human subject research studies. So if you want to do research on human subjects, you have to go through the IRB board to be approved. So how would you define incidental funding in a research context? Well, in contrast to the return of general individual study results to subject, incidental fundings are discoveries of individual level fundings that are unrelated to the research study objective itself. Examples will include funding an indication of lung cancer in an X-ray done to look for tuberculosis for research exclusion criteria. So in your protocol, you have exclusion criteria that exclude subject with TB. You do the X-ray, you find the lung cancer, so it becomes an incidental funding. Or the most common example is the discovery of a genetic marker of variants unrelated to the goals of the study. Now, while most incidental funding will be discovered during clinical research and be medical in nature and have potential effect on the subject's health, we do see incidental funding in social behavior and other fields of research, and they are as important as the ones seen in biomedical research. And actually, those ones might even have implications that are beyond medical care. There are also some fundings that could be considered both individual funding as well as incidental funding, which add actually to the complexity of the topic. So incidental funding can be, and again, keep in mind, this is research, can be anticipated, means that the researcher will know in advance that, an incidental funding is to be associated with a particular test or research procedures. But they can also be unanticipated, means that cannot be predicted given the current state of the science, during the study or at that time. And the researchers cannot specifically plan for this, but in these cases, we would like them to consider what they might do if this happens, especially if they end up having an incidental funding that is both actionable and life-saving. I would like to, make the difference between incidental funding and secondary funding. I know most of us, we use the word interchangeably, but there is a difference. And the key difference lies in the intent. The incidental funding will be discovered unintentionally and can be anticipated and unanticipated, as we saw. But the secondary funding is something that is not the primary focus of your research, but will actively be sought after by the practitioner. These fundings are often pursued based on recommendation from expert bodies or consensus among practitioners. The easy example here is the list of gene and variants recommended by ACMG when the labs are performing large-scale genetic sequencing. It is also important to define what is meant by the return of incidental funding in a research context, because the duty of a PI or researcher toward a research participant is different than the responsibility and the duty of a physician toward its patient. And it comes with different issues that IRBs they have to deal with, but also researchers and institutions. The first issue is related to the method itself. Do we want them to have a discussion face-to-face? I mean, just the PI, researcher, and the research participant, or we want them to include from the front, from the beginning, physician or a specialist? And what is the best method to return those incidental funding in research? Is it by email, a phone call, face-to-face? Because some of the research will have only one visit, so you saw that research participant one time, there is no follow-up. So how do you contact us, that participant to give him the research, the incidental funding back if he or she qualify for that? However, we have to keep in mind that because most of those incidental funding will have clinical relevance, so we have to deal with them the same way we deal with incidental funding in clinical research. The most important one and the most complicated should be communicated face-to-face, even in a research context. The return of incidental funding must also take in account the subject status. When you have an adult who lack capacity of understanding and the competence to understand those incidental funding, then this information should be given to his or her LAR. And if you are dealing with minors, then you involve the parents and the guardians. Another issue to consider in research is the qualification and the composition of the team or the individuals that will be, returning those incidental funding. Do they have the right qualifications? Usually, the common practice here is to involve the treating physicians, the investigator, the research staff, the IRB, the hospital ethics committee, and or a genetic counselor or any other relevant specialist, depending on the nature of the incidental funding that you have to deal with here. Well, over the years in research, there have been a lot of arguments for and against returning funding in research. And however, the consensus now is that researchers and IRBs should both carefully consider the potential benefits and the risk of disclosing such funding. In some cases, the disclosure might lead to obtain, life-saving medical intervention or help participants make an informed decision regarding their health. However, disclosure could also lead to needless future testing, additional incidental funding, anxiety, distress, and potentially with no medical benefits. So, in conclusion, researchers should evaluate. Should evaluate whether the prospective benefits of an action outweighs the risk and how their incidental funding management will affect the participant as an individual, but also how it will affect their ability to create generalizable knowledge, which is the essence for a researcher, is the generalizable knowledge. This exercise of weighting the harm versus the benefits of returning incidental funding to research subjects is primarily supported by the principle of beneficence in the Belmont report. However, there are three other ethical principles identified being also applicable to the return of incidental funding. There is the respect for persons, under which the researcher will have to disclose in the consent form all the potential incidental or secondary funding, which will make the participant make an informed decision whether they want to receive them or not. Under the principle of justice and fairness, the researcher must consider how policies, and actually even institutions, will have to consider how policies around the sharing of those fundings can either assist or disadvantage participants and the broader research community. And finally, while the intellectual freedom and the responsibility promotes the freedom and of researchers to explore and innovate, they are also expected to respect the trust placed in them by those participants, and consider the application of those fundings when they are dealing with. I think we should have waited for that done. So the question is now when we should return, again, from an IRB perspective, research perspective, when we should return or not return accidental fundings in research. The recommendation from the regulatory bodies are summarized in this table. The more likely, do you see the mice, or maybe pointer? No, it's okay. So if you see box 1, that's the most likely the funding are to be validated, and actionable. The more justification there is for providing them. And by validated, we mean that those funding have been validated or generated in a certified CLIA lab for biomedical research, or by a test that has been approved by the FDA. And actionable means that it can be either clinically actionable or personally actionable. And on the other side of the spectrum, the fundings that are not validated and not actionable carry the least certification for return. In between, you have other cases where, but before going that, let me give you an example for, an instance in the research where, the fundings are validated and actionable, and the recommendation is to highly return them to subjects. For example, let's say a researcher is reviewing a bunch of clinical tests that were done in a clinical care setting, like lab tests or ECGs or X-ray, for example, and he or she found an incidental funding. So those tests are validated because they have been done in a clinical setting, in a CLIA certified lab, and the funding are actionable. It has clinical significance. So the researcher must return those subjects to to the research participant. For box 2 and 3, IRBs take them case by case, because if your results are not validated, we will ask the researchers to actually have them validated in a CLIA certified lab before we allow them to return them to the subjects. And if it's not actionable at that moment, means that your funding has no clinical significance at that moment of the research. It doesn't mean that it's not going to be in 2-3 years with how the science moves very quickly. So we recommend that they give actually the choice to the subject, whether they want to know when the information is available, if they want to be contacted and know about the funding when it becomes actionable clinically. From a regulatory point of view, and I draw the line between regulation and recommendations or guidelines. From a regulatory point of view, there is a silence. Both, I'm from a U.S. institutions, both in U.S. but also locally. The regulation do not explicitly address whether incidental funding should be returned to research subjects, which actually kind of leave the researcher, give the researchers and institutions discretion in handling such fundings. But as I said, there are guidelines documents that's been published since 2017 by both HHS and MOPH. And I put here, this is exactly the language used in MOPH guidance when it comes to returning incidental funding in research, and it's mainly focused on the genomic research. And MOPH encourages the return not only to the proband, but also to the family members. However, they said this is not a requirement when conducting genomic research. They also recognize that in some cases, there may be a legal or medical obligations to inform subjects for certain incidental funding, but again, they don't define those legal and medical obligations, and which gives the freedom again to the institutions and the clinical care providers to kind of have a policy that or guidance documents that explain those instances. In terms of international guidelines, recommendations for secondary fundings in genomics have been published by several professional societies: the European Society of Human Genetics, the Canadian Society, ACMG. However, the guidance is variable and it's very specific to secondary funding, and we saw there is a difference between secondary funding and incidental funding. And actually, ACMG recently changed its terminology from incidental to secondary fundings. And they clearly actually, for ACMG notes that incidental funding identified in genes beyond their minimal list of secondary funding genes might be returned at the laboratory discretion, while the European Society notes that this area is beyond the scope of their analysis. So in light of this complex gray regulatory framework for research, what will constitute an ethically appropriate plan for management of incidental funding and secondary funding in research? Well, researchers, they have the ethical duty to plan for incidental funding, whether common or rare, to the extent possible, obviously, and however, they do not have an ethical duty to seek secondary fundings. They should also develop a plan based, ahead of time when they're writing their protocol on evidence about the analytic and the clinical validity of those fundings. And they should also carefully consider the benefits, the risks, and costs associated with this disclosure. Now, we have to note that in some cases, researchers will not be able to return incidental funding. For example, when they're dealing with data coming from biobanks, the majority of biobanks will give the data de-identified to the researcher. And there is no way for the researcher to recontact the research subject. So the recommendation, or actually we had a case just recently with Qatar Biobank where one of our researchers did find an incidental funding in the data that he was analyzed for QBB data that has, independent from his research hypothesis. And we had meetings, we involved all the parties that are relevant, QBB, IRB, QPHI, the scientific person, ourselves, the PI, and we discussed actually how are we going to assess the actionability of these mutations and the process of disclosure, and if it fits the criteria of this disclosure, who's going to disclose and how. So I will always encourage to, have a collective discussion when it comes to these cases. Some incidental funding could fall outside of the researcher expertise, and in this case, the IRBs will want them to, use ad hoc experts, and even IRBs sometimes may not be qualified enough to review and determine the incidental funding return. And again, talk to the experts when you don't have the expertise. Very important points when it comes to return incidental funding in the research, word is the participant preference. If researchers plan to inform participants of certain type of incidental funding, they should decide in advance how to respect the wishes of the ones who has opted out of receiving this data or these fundings. And if a researcher have an ethical obligation to allow participants to opt out of receiving clinically and actionably and life-saving funding, they should not enroll such individuals in their protocol. Actually, they should have an exclusion criteria in their protocol to exclude them. And I don't know how this will fall under the Islamic, because I just heard that we have to. But if someone doesn't want to, be made aware, it's maybe easier to just involve them in that research. If a research discovers a potential life-saving incidental funding for a participant who has opted out, the PI should seek advice from an IRB and expert. We also have to pay attention to the researcher, another researcher responsibility is the qualification of his or her team post-disclosure. Because sometimes once you disclose the funding, the researcher will be asked to provide, or we need to provide basic education and information about the nature of the funding, advice on how to seek care from specialists, refer the subjects to clinical specialists if required. So you want that returning team, or the team who is involved in the returning of the funding, to be aware of the local, regulations, the local healthcare. How can I say that? System. Thank you. So at Weill Cornell, in the protocol, we require, the researchers to add in their protocol, when it's applicable, a section about incidental funding, and those are the points that we want them actually to talk about. We want them to identify, assess clinically significant or medically actionable incidental funding, the type of results that they might return, the qualification of the team involved, the time frame, the recipient, plan for sharing incidental fundings, plan for allowing subjects to withdraw, and plan for further care for the subjects after the discovery or after the disclosure. And most of the time you have to hold the hand of the researcher through the steps. So we have questions for them that they have to, and definitions and examples, including the definition of incidental funding in the templates, including actually, whether it is anticipated, unanticipated, the difference between secondary funding, and we refer them to the ACMG list. We want them to say how and when and what are the fundings that could be discovered, what is the basis for returning funding, and remember that table of POCs 1, 2, 3, 4. So we kind of translate that into text for them to help them think around the issues and the questions. I'm not going to go through the whole thing, but happy to share the slides if you would like to. This is a sample of the wording that is used in the consent, because remember, when you talk to a research participant, you have to use a lay, language, and we remind them. The first box is we remind them what should be said in the consent, and then there is an example of one of the studies that we have. So finally, process-wise on the ground, if a researcher uncovers potential incidental funding, the funding should first be assessed consistently with what's been approved by the IRB in the protocol and consent. Experts should be brought into the table as relevant, and before meeting with the subject, the returning team should first determine the clinical implication of the results for the research subjects, re-evaluate the subject's medical history, family history, physical examination in light of the funding, review the subject's preferences indicated in the consent form, and weigh the potential harms and benefits of reporting the funding results, the funding results. Just keep in mind that while analyzing the data, this data should stay de-identified before a decision is made whether to return it to the subject or not. The last box it's specific to when the protocol has no reference to incidental funding and you find something, the recommendation is to talk to the IRB and we'll take it case by case. I think that's all from my side, but if you have any question, I'd be happy to answer them.
Thank you very much, Rana. Now, the floor is yours, Ghali, to talk about Islamic perspectives on gen ethics. Yes.
Not so much.
20 minutes.
Yes. No, I'll do it less, I think the way is well paved for me to go to the core of the business. And now, speaking about the Islamic ethical perspectives,
دكتور راجي لازم
معلش.
تدخل هنا.
Yes. Sorry. I made a mistake. Okay. So this is my disclosure. These are the main objectives. This is my outline. You remember in my introduction, I ended up here that we have questions. What to disclose, what not to disclose of these incidental findings or secondary findings, and I hope this terminology is now clear to everybody. This was not a question coming from one person, questioner or mustafti, but it's a big question. It's coming from institutions, from the scientific community, from the clinical institutions here in Qatar and beyond. The a bit frustrating aspect, as you may have noticed now, there is no answer for this question. There is no one single answer for this question to say that yes, disclose them, or no, don't disclose them. There is no such a thing. We always say in the field of bioethics and ethics in general, we always teach our students, the art of an ethicist is that you always say it depends. So once you say it depends, then you are on the right track. If you are hasty saying yes, do, no, don't, then most likely you will be in trouble. So it always depends. This is not only an Islamic perspective, but it is an ethical one. So ethicists, we have the very famous joke about the IRBs, people in the IRB. If you have 3 members, you will end up with 4 perspectives. So the 3, they will disagree with each other and will have a 4th opinion by combining all of them. This is how ethics most of the time work, because we are dealing with challenging issues. It's not a straightforward, simple issue. Now adding the Islamic perspective. The Islamic perspective is not only about benefit harm or benefit risk assessment within the narrow scope of health related issues. So it's not only about the clinical utility, it is not only about actionability. All these things are included, but more importantly, it relates to that. This person, whether a researcher or a patient or family, they care about that I don't commit a sin in my relationship to God, because God is the creator who created us, who gave us this knowledge, and we will be held accountable before God about our human actions, including what we do about these decisions, revealing the incidental findings or not revealing them, etc. So there is God on the equation. So we need to know if what we are doing will be acceptable from a religious perspective or not acceptable from a religious perspective. Like other moral philosophies, we need to work with categories. So there is no one single category by answering yes or no, or as many people will think, ethical or unethical, or evil or good. These binary divisions do not work in such complex issues. So we usually work with categories. In secular bioethics, we have usually 3. Started with 2. By time it became 3. The last one it became 4. The very recent one, like the work of Tom Bishop and Travis and the principles of biomedical ethics. But in Islam, we have 5. So the most sophisticated, I would say, in the Islamic perspective so far, in all moral philosophies that we have 5 in Islam, and these 5 are coming from the discipline of Islamic jurisprudence, and originally coming from theology and theological discussions about the morally good and bad actions, التحسين والتقبيح. These are the 5. If you remember what Dr. Saeed mentioned and what Dr. Amal mentioned about that we have different categories, also Dr. Tawfiq in his analysis of the different cases, and sometimes you have benign, likely benign, pathological, likely pathological. There is an action to be done, there's no action to be done, but maybe in the future we can have it. You cannot accommodate all these possibilities if you don't have a complex framework like this one. So in Islam in general, to make it simple, human actions can be divided into five. The most important that people need to care about are two. The obligatory things that you have to do, and if not, you are sinful, like praying 5 times a day, fasting during the month of Ramadan. The month is approaching, to keep in mind that this is one of the obligatory acts, and the prohibited ones, things that shouldn't be done. And if you did with no compelling reasons, then you are sinful, like having relationship outside marriage, like drinking alcohol, all these things. And between the first and the fifth, the obligatory and the prohibited, we have the things in between. Close to the obligatory, we have recommended, so things that you are encouraged to do. If you remember, Dr. Amal mentioned the guidelines of the Ministry of Public Health. They said, we encourage researchers to do, but it is not obligatory, which means it is recommended. It's in the second category. And close to the prohibited are the principal, discouraged, makruh. So you are recommended to do it, but if you did, you are recommended not to do it, but if you did, there is no sin, but you didn't do the most ideal option. And then the permissible, which is the in between, the morally neutral act. So when we started doing this back in 2013 and 14, we thought this framework, in discussion with our colleagues, the scientists at this time, we had Dr. Tawfiq bin Imran and Dr. Saeed Ismail, when we started discussing these issues, and we started to put the disclosure and non-disclosure in one of these five. So just for the sake of time, I'll speak about two. And for those who are interested about more, they can read the book and the publications that I will show you later. So what is obligatory? Things that we argued, and I mean by we here, the interdisciplinary team, we're working on these things. The first one is that the likelihood of incidental findings. As we said, they are unplanned, unintentional. You don't plan to do them, but they are expected. You know that you are going to sequence a whole genome. It's not like any other test and not any other clinical definition. There is a likelihood that we will have incidental findings. So while getting the informed consent of the research participant or the patient, you need to make this clear to the patient. There is a possibility that we will have findings beyond what we are looking for. Are you okay doing that or not? So this should be very clear. Of course, in the research setting, if the person says, no, I'm not interested, and I don't want to know this part, and I don't want to have any research including incidental findings, which means this will be crossed out. You will not be part of the research because you are not interested in doing this type of research. You get nervous about these things and you don't go on to them. So the first one is the likelihood of the incidental findings that should be revealed from the beginning. The second one, the life-saving information that you can come across incidentally, unplanned, unintentionally, but it can turn into life-saving issues, as Dr. Saeed mentioned. In the beginning, there was no strategy and mechanism for returning this type of results. When we started the research, we came to the conclusion together, no, that this is not saving people's life in Islam in particular, and I would claim even universal morality. Saving people's life is not a good act or a noble act, it's an obligatory one. There is someone, the example he mentioned, I am praying, which is an obligatory act of worshipping God. It is the last minute in which I can do the prayer because there will be a time for another prayer. And then I found someone drowning in the sea. I can swim. I know that I can save this person and there is no danger for my life. I have to cut and stop the praying and go and save the person, because saving life is an obligatory thing. You cannot avoid that. So in the case of incidental findings, as a researcher, as a clinician, I see that someone life-threatening condition, and I can save this person because we are a clinical institution or a hospital. These findings are validated, all the conditions that my colleagues spoke about. Should I reveal these things to the person? Yes, you have to reveal to these things. And we say in the informed consent, this should be clear. And if the person do not consent, it should be crossed out from that because it is an obligatory act. You cannot see someone drowning, dying, and you do nothing about it. The last point that I want to say is about what is prohibited, what shouldn't be communicated or disclosed from the incidental findings. As you may have really understood from my colleagues that the findings when you sequence someone's genome are not only health related or clinically valid, but it is the book of life. You know things about the past, about the future, not only about your health condition. One of the important things that happen and represent a difficulty for the researchers and clinicians is about the so-called misattributed paternity. You have a child, the child has a condition, you try to sequence the whole family, the father, the mother, and the others, in order to see where are the ACTGs are different, and you say, okay, maybe this is the issue. While doing that, you discover that this child does not belong to the family, especially the father in this case. He is not biologically related to the husband of the woman. What should we do in this regard? We came to the conclusion in the studies we had, and I had the scientists on my side as well, don't do that. We detailed the reasons why you shouldn't disclose these findings. First of all, this is not your job. When I have issues about the lineage of my children, I think that this child does not belong to me, is not part of myself, there was cheating from my wife, etc. I don't go to Qatar Genome to do that. I go to the court and start to take a legal action about this. So it's not your job, it's not your work. And if you get involved into this, there will be a big issue. Imagine that people will say to each other, you know what, if you have questions about the loyalty of your wife, go to Qatar Genome, go to Hamad, go to Sidra, go to Wilcon now. We will have different things than what we have now. This is not what these institutions are made for. So this is number one about the agreement, the contract that you have between yourself as a research participant or a patient and these institutions trying to provide service to you and the country. The second thing, important thing, is that in Islam, from an Islamic perspective, paternity is not exclusively biological. Paternity is beyond the biological. In Islam, it is categorically prohibited to have reproductive plans to get children outside marriage. This is the general ruling, Sunnah, Shia, Ibadi, everyone. We had a possibility in the past, it has been blocked now, which is the slavery, so we don't speak about this now, we come to universal agreement that this is outside the scope now, so we only have marriage. So if you want to have children, you have to be married. Once there is marriage, which we call firash, marital wedlock, automatically the husband is the father and the wife is the mother. And we cannot do otherwise unless we have very, very strong way to challenge this, and we call it li'an in Islam, a very difficult and tough judicial procedure and so on. So anyhow, the getting the children is part of a bigger setting, which is the marriage. And this marriage is not only a civil contract, but a religious one, which automatically initiates a set of mutual rights and obligations between the husband and wife, and related to the child and protecting the best interest of the child. Challenging all these things, because you have an issue, because you have biological relatedness issue and so on, does not give you, as a researcher or as a clinician, enough ethical justifications to challenge this well-established rule in general. So paternity in Islam is not only a biological issue, but it is first and foremost a marriage based paternity. The last point, the last problem we spoke about, is that it will be unfair if we go on with this. Because the discovering maternity problem is easier, much easier, because the woman is pregnant, everybody sees, etc. The issue is always with the man. So this biological or genome sequencing will discover the paternity most of the time and not maternity, unless we have mixing in the IVF clinic and so on. So we speak now about the paternity. In this paternity issue, the woman will be the victim all the time. And what we will think is that this woman committed adultery. She had extramarital relationship, which is not true, even from a juristic perspective. We have discussions among Muslim jurists. If a woman is pregnant, a single woman is pregnant, can we accuse her of committing adultery? And many of the jurists said also, you cannot do that. Why? Because maybe she was raped. Who said that it was consensual? And maybe this woman was raped by someone from the family. This can be a father, this can be a father-in-law, this can be a brother-in-law, and she didn't want to make a disgrace in the family. But once this information will be disclosed, this victim will become a criminal automatically, and then you wait for years if you can do that. And all the time, the cheating man, will not be discovered in this. So there will be, when it comes to cross-gender relations, there will be serious unfairness, also the stigma for the family, not only the woman, but even the husband of the family, the best interest of the child. So we have enough reasons to say that the so-called misattributed paternity findings shouldn't be disclosed from an Islamic perspective. And by the way, internationally speaking, most of the institutions have this as well. It's not only something because Islam is saying that, but it is part of a growing moral consensus among genome institutions. I will stop here. These are just examples, and you are welcome for your questions. Thank you so much.
Thank you, Dr. Ghali. Thank you, everyone. The floor is open for Q&A. We have almost like 18 minutes for your questions.
Thank you very much, Dr. Ghali. My name is Sikandar Akhtar in surgical background. As you said about this,
You can press
as you said about ethical issues, the first statement which you talked about is already being done by informed consent by the surgeon. So everything from A to Z is going to be explained by the surgeon, operating surgeon. So these are the operative. You have this diagnosis. This is going to be the measurement. This is going to be the side effect. Everything is being discussed like this one. So I think it's very much in supplements what you said. It's informed consent. And second thing, parenting issue, it itself is a huge chapter. So if we mix it with this one, I think it takes too much time for this one, because I think, as you said, two examples given, we are making Badu and someone is dying. It's not something religious, it's your inner feeling. As a human being, you are going to save him. So once you have something like parenting issues, I'm pretty sure that 99% of the person related with this process will not disclose it. And itself is a huge chapter, huge chapter. So if we mix it with this medical issues, I don't think that means it's my.
Thank you. Okay. There was just an issue while we were writing the first report, the WISH report. We were also consulting with our teachers and religious scholars and so on. So one of the advice we got is that we say to a Qatar genome, you can reveal statistics, not names, but like we say, we found 10% misattributed paternity, for instance. So that we know as a society that we are on the right track or not. So we couldn't. We didn't agree with this opinion, because I remember at this time it was like 10,000 or no, 3,000 sequenced genomes at this time. So imagine that we try to avoid the problem of a couple of people who may be discovered. But by the way, we don't have any idea if this ever happened. But let's imagine for the sake of argument. We have like 3 cases. problem with these 3 cases. But then we published the results in the newspaper saying that pathogenome program, they found 10% or 5% of the people with misattributed paternity as one of the results. We will make problem for 3,000 people, not for 3 or 4. Even we didn't go with that. So we were quite strict in saying that this should be just completely dark, and we said even as long as you can avoid this issue while you are doing the sequencing of the genome and make it dark so that nobody sees that, please do that. Yeah. Thank you.
How those cases could be backed on cattle genome while there is no pedigree collection and relationship data collected within the samples and the clinical data?
I said we didn't have any single case. We were speaking about the general rules. That even that general statistics we see no. Of course, it's more likely in the case of the clinical testing if you are doing a test for a family. But whatever, if clinical research setting, it doesn't matter. And the issue is too complex to say that under certain conditions you can have. In the book, I spoke about one opinion by one of the colleagues at Qatar University, just for the sake of transparency, and people who are interested can read the book. He came to the conclusion not only that it is possible to reveal it, but it is obligatory to reveal it. We have this diversity of opinions within the Islamic tradition. Nobody has monopoly on the truth. But I addressed the perspective and I responded to it point by point, etc. We have this. I'm not aware of any other person who said that it is obligatory among Muslim religious scholars, but we had this perspective. Yes, thank you.
So I have one question to Dr. Saeed. Okay, please go ahead.
So I have a question to the four of you. It's regarding the laying of non-actionable finding or incidental finding. How do you see that? And is this like ethically possible to relay those data? Is the benefit weighting the risk of relaying such data?
Thank you.
It's a very good question, actually, and it's a very good question, and it's for clinical settings, routine ones. It's different from us as a large scale project because you're moving, sequencing a lot of genomes, a lot of participants, and at the same time, science is developing. What is now of unknown significance is tomorrow either benign or pathogenic. So it's a continuous sort of revision and curation of your data and the science, and then continuously going back and identifying who are the carriers and going back to them. So logistically, it's a huge mission. If you launch a national program saying that I will return results to participants, and then you discover that 5 years later, someone got some form of cancer and he was a participant and you did not reveal that to him because science then was not established, then would he go back to you and tell you, why didn't you tell me? And it's a very huge gray area, and there are no easy answer for that, but it's a good question. It's not a snapshot, it's a continuous revision and curation of the data and the science and going back to your participants.
I second Dr. Saeed, and from an IRB point of view, actually, I quickly touched base on that box 3, which is validated non-actionable at the moment of the research study. The recommendations, from the IRB is that to ask the patient or the subject whether they want to know in the future if that mutation or incidental finding become actionable. But as Dr. Saeed said, it comes with a lot of administrative burden, and also the risk of actually losing the contacts with the subject. And the researchers have to be careful in terms of what they promise the research subjects.
But I think in this area, there will be a big obligation in providing a pre-counseling or test pre-counseling information before allowing even the participant to choose to get this result, because I might choose to get such a result without understanding how that would be applied to us, and it could create, as Dr.
Tawfiq.
Tawfiq have mentioned, anxiety in the community, and not only to the specific person but to the whole family member for such data, while the science will be developed after 5 years. And is this like, could we also assume that we are obliged to provide such data which will be discovered in the future? Or maybe reviewing all of this after every 5 years and try to find what we would relay now in this stage?
One easy exit out of all this is what we've all mentioned, ACMG. So luckily there is something called the American College of Medical Genetics. They decide that, and it's a consensus globally that we follow them. So it will never be as comprehensive, as exhaustive as you would wish, but
so we follow actionable, not non-actionable.
But the list is increasing. The ACMG knows Dr. Tawfiq is getting larger and larger every time. So it's dynamic.
Yes, I think, like, for example, diseases change with time. For example, diseases maybe 5 years ago, there is no proper preventive measures, or there is no proper treatment. But now, for example, 5 years later, there is a treatment, or there is guidelines or surveillance. So maybe you want to add this to the list. So it's a dynamic, exactly.
A dynamic reviewing of actionable list, and whenever we receive an actionable, we could go for all the legacy whole genome sequence and review it again and review those results. That would be like a more proper approach for participant or for relaying secondary finding.
Exactly, just like in newborn screening, for example, newborn screening now, for example, disorder like spinal muscular atrophy, before 2016, there is no treatment. So why you add it? Just, you have a healthy newborn and you tell the family your child will have this disease and this is, a lethal disease, but there is no treatment. Why you tell them, right? But now I think we have 3 treatments for this disorder. We sit with the family, we tell them your healthy child has this disease and we can give a treatment. And if we give it now, pre-symptomatic, the child will be normal. So they will be happy, right? And there is, a improving in the outcomes. More or less the same, yes.
Just a quick footnote to make the life of our scientists a bit more difficult.
I want to, not me.
No, it's just sharing the thought. ويسكن Arabic علما ينبغي عليه عمل. So should be actionable. If there is no action, what's the point? But what is actionable? What is actionable? Most of the time we hear here clinical. So there is a disease, we give a treatment, and that's actionable. But actionable is broader. Is broader than that. Even in secular ethics now, they speak about social utility, not clinical utility. It may be helpful for me for something else beyond that. So, for instance, if we have the gene a mutation responsible for Huntington disease. No treatment, and it is certain, almost deterministic. The person will get it. You smoke, don't smoke, exercise, you don't exercise, you will get it. Okay, but what is the point of giving this to me? Yeah, there can be other non-clinical benefits, like, for instance, reproductive choices. I will not marry, no, so that my children will not be orphans and stuff like this. Maybe I am married and I have not the best relationship with my wife. I will get this fixed. My relationship with God is not the best relationship, so let's make it fixed. So there would be benefits. In order to make the life not too difficult for the scientists, we say there should be prioritization. There is so much administrative work related to this. So we say there are boxes to check. We start with the most urgent, the things that are clinical, the things that are can help the people, save the lives, and so on. Once we do this and we have the administrative capacity and so on, we can think of other things. So we can give them homework once they are interested. So there can be other actionable, but beyond the clinical understanding of what we mean by actionable. Thank you.
We still have some minutes.
Last question to Dr. Said. Thank you very much for your informative lecture, although all lectures are very good and informative. You know, in current situation, everybody loves to talk about artificial intelligence. Some talks in favor, and many people claim that it supplements human actions. So as you talk about these genomes, there is tons and tons of data. So do you see any role AI can play in this field? So
And definitely, there will be a huge role for AI. AI depends on large data, and what we're doing is big data. So they have to meet. People around the world are discussing what the potential role of AI in genomics and multi-omics in particular, linking all these huge data sets and associating it with specific phenotypes or diseases is something that needs AI. So definitely the whole field now is looking into how to benefit from this new emerging player in the field. And it just came at the time when we were producing all these data, and we know that as humans, we cannot digest it that quickly. So we need help from machines. So definitely is a big role.
After retirement. Because now we don't want to lose our jobs.
Another question is curiosity, because we have tons of data, right? And here 60% of the population is expatriated. So I do believe sometimes we see that this data is also coming from the expatriates. So when they leave this place, so how is going to be helpful for this place like this? So sometimes I'm curious to know about this. How it's going to help this.
There's so many examples, but it's happening. It's a huge area where AI meets big biomedical data.
Well, if there is no further. Okay, just one last question.
Thank you so much. So, Dr. Tawfiq, he mentioned about consanguineous marriages. So, I was curious to know that during your findings, what did you find, like the link between, of course, we know the link between genetic disorders, but what was the response of the participants, and Dr. Ghali, how to reconcile this with the, permissibility in the Islamic tradition about consanguineous marriages? Yeah.
To your based on your answer, I can.
You mean the role of consanguinity in genetics?
Genetic disorders,
Yeah.
and we see that especially in the Middle Eastern countries, the culture of getting married to your cousins and first cousins and all that. So
Yes, so yeah, you are right, and this is really very important point to discuss, especially here in our region, the Middle East or Arab countries. Consanguinity is high, and we know this is one important factor to increase genetic disorders. Actually, we see, for example, families with more than one disease, or even more than one disease in one child. Right, and this is, I think, where is the role of advanced technology, whole genome and whole exome. Before we think, one child, one disease. Now I think we think, outside. But we don't want to blame consanguinity, of course, for everything, because we see genetic disorders also in other societies where consanguinity is even prohibited. But I think, here it comes the role of preventive strategies, right? And this is what we were meeting before this session. I think in consanguineous, rather than just saying, don't marry from your relatives and, creating a lot of social challenges. And no, you provide them with preventive measures so they can take and they can prevent this from transmitting to the next generation. I don't know if I answered your question.
Yeah, based on this information. Based on this information. What I understand also in my discussions earlier with Dr. Saeed, that consanguinity and genetic, having children with genetic condition, there is correlational, but no causal relationship. So they do exist together sometimes, but we don't have enough evidence to say it's deterministic. Once you marry with your first cousin, you will have this, and all the people will have this. So we don't have a scientific challenge telling us we have to revise consanguinity, the ruling for consanguinity, which is originally permissible, but now because it's so harmful and deterministic, then we have to revise. We don't have that. But beyond that, and before the genetics, we have discussions in Islamic jurisprudence about consanguinity. And there are different religious scholars who said that it is reprehensible, makruh. And speaking about the five categories. So they said it's reprehensible. And some of them mentioned why is this? Because they said the to be born child will be weak. حتى لا يأتي الولد هزيلا or ضعيفا or something like this. So, and we have a statement attributed to Umar ibn Khattab, speaking to a tribe that we were marrying together for generations after generations. He advised them not to do that. Because and Imam Shafi'i, who was known to have some medical knowledge, also spoke about that. So we have this from early on. So I would say it's on a case-by-case basis. So you have premarital genetic testing, you have results. Based on these results, you need to behave responsibly. So maybe through the preventive measures available, because it's almost never deterministic. So you can use IVF, pre-implantation, prenatal, and so on to avoid getting the child with severe genetic conditions and so on. Thank you.
Well, concluding this very interesting, very informative session, I would like to thank our guests, professors, for their informative presentation, and also thank you all. And by the end, I would like to invite you to some refreshment here beside the conference room. Thank you very much.
Thank you so much. Thank you very much for moderating. Thanks a lot. الله يبارك فيك. شكرا جزيلا على الدعوة.
Very good to see you on campus. Oh my gosh, how are you doing?
Okay. Thanks for coming.
Yes. We're in the same mood. In their talk.
How are you?
Thank you,
Thank you
Dr.
very much.
Tawfiq. Thank you.
They find that, you know, being in the West. So, you know, they very much approach. What I do without. No, I just what is genetic implication of that?
We were working together at the
Thank you so much, Anita.
Thank you. Enjoy that.
Yes. Did I tell you that I know Dr. Tawfiq for the past 12 years? He's my daughter's genetic counselor. So, and he's been one of the biggest heroes. Like, you know,
I've met him in one conference for precision medicine, like back in last year.
Oh,
Yeah.
wow, okay. Are you into precision medicine research?
No, because I went for Kyle Booth there, so for End of Life book at that
That's
time.
amazing.
I wished I can sign for apply for the master there, but it's not really like
Aligned.
I need to do an effort to apply to this master. But if you ask me, so this is my passion.
Really?
Yeah, I love this field. Yeah.
That's amazing.
Yeah.
I have no idea that you had an interest in this.
Yeah.
Oh wow, so you're in a good place to kind of explore and create a
Yeah,
network.
but
And, you know.
maybe it's too late for me to start something new.
No, never. You should see all the older people who are in our programs and all of that. I mean, mashallah, it never.
I heard there's a mom in applied ethics and she's doing good. So I don't know if she graduated or she's a new student, but I heard from her Marta's once speaking about her. So yeah.
Okay, mashallah. I mean, you know, you get all sorts. We've had 60-year-olds. We've had 60-year-olds join master's programs. You know, like mashallah.
60-year-olds. And I'm safe in the safe range.
I totally. You know, they're so inspiring because they're like
in
it's never-
Canada, I have a colleague like peer student. She was like over 60 years old, and she's
they keep going. Yeah, so no, it's never too late. It will be so interesting to see you in the academic arena. Yeah, inshallah. It was very cool to meet him in a college. It's like because we have an appointment in 4 months in his office. So it's a very different.
This is
environment.
medicine.
Yes. I mean, he deals with HMC to some extent as well because there's not that many genetics counselors in the country. But we're very grateful that he's never let us go. Like even after the work with us is done, he's always there.
Yeah.
You know, and WhatsApp him for all sorts of stuff.
No, he's very kind.
Very wonderful. Alhamdulillah.
Yeah, alhamdulillah.
I just tell me.
So I just wanted to discuss when is that write-up? Is there some due date for that?
Here's the thing. So you have to kind of understand this. It is targeted towards Ramadan. To come out in Ramadan, and ideally not in the last week.
No, actually, because I wanted to work on it during this week, but so far I haven't started. But I have the idea. I shared it with Dr. Abdul Fattah, who's teaching us globalization. So it's I want to this McDonaldization and all that. I wanted to be part of that. He really liked it.
But don't wait for the end of the term.
No. That's why it suits me as well. I want to finish it because 3 papers, and then Ramadan.
No, but because the thing is, even the description that you sent, if I'm not mistaken, is about 500 words.
Yeah, I think
right? And
1,000.
OBED is 1,000.
So it's just going to be like a blog sort of a thing,
Yeah,
like just a write-up.
opinion pieces are not. They're you're speaking to me about a topic.
I think just the one like Dr. Gavin, I read his article on intermittent fasting and Ramadan. On it will be published on the HPK website.
So it will be published. So for sure, it will be on the website.
Okay.
Secondary, it will go out. They will be pitched to local newspapers.
But the thing is that whatever I wrote was just an introduction, so I still have to make a conclusion. So for me, even if it's 1,000 words, for me to you've been through it. To arrive at a conclusion, you have to think through and you have to think big and then squeeze it. So,
but an opinion piece doesn't always have to have conclusions. You can even have possible strands of where it can go next.
Right. Okay, so I can. You mean to say that I can just expand it to 1,000 words and then just present it to you? Maybe then you will have a look and just let me know. Because I was thinking in terms of the term paper that term paper introduction and the argument and all that.
1,000 words is too brief.
Yeah, too brief.
So it's literally about exposing the public to an idea. And kind of taking them, why is this idea interesting? What implications does it have?
Right.
Yeah. It's something like your dinner table conversation with your kids.
I think yes. I think I can manage that because, like you said, I didn't even count the words. But if it's 500, then
exactly. Write a little bit more.
Yeah, you like the ideas, like the basic ideas, sitting together, communal sharing, and all that.
How hard this is, like I'm just saying but I know because I also just really wrote an opinion piece for another entity, and I'm just like, oh my god, am I getting my point across or not?
Right.
But the idea is just put it down in.
Sometimes it's hard writing in 1,000 words, especially when you're used to writing 5,000 plus.
Yeah, I know, but it's great practice to be able to speak to the average Joe.
Oh yeah. Another thing is that this is the thing that some sort of a non-academic language.
Yeah, a non-academic language. Exactly. So, and that's just basically talking to your kids at the dinner table. So they say like ideally should appeal to a 12-year-old.
Okay.
Like a 12-year-old should be able to understand what you're saying.
12-year-old, right? Okay, I get your point. Okay, so that's I'll try to. I can't promise, but I'll try to do it. In the first week of Ramadan.
I would say if you can manage by the first week of Ramadan, this leaves about 1 week to flesh out editing Ramadan. So at least it comes out in the second half of Ramadan, because it's not as if you publish today, it will be out tomorrow. There's still a process, translation, it takes time.
Yeah.
So I know that last year one student is like, yes, I wanted to do the whole thing, but by the time they edited everything, it was the last few days of Ramadan.
No, I don't want because
and then you lose the fizz.
No, it has to go. So, but then you'll it will be published by the end of Ramadan or first week. No, not the first week, not possible.
Not first week possible. But basically give it about a week after you submit.
Okay.
Yeah.
But what is your target that you want to be published in the first week?
No, to me it would be. I know first week would be.
Ideally, not like generally saying it should be.
So ideally,
if send the message across, ideally it should be.
Ideally, they can submit by the 1st of Ramadan. Then by 7 to 10 Ramadan, we can actually, have it out.
Yeah, that is a safe zone.
Yeah, so something like if you work on it over the weekend to get your thoughts in order, submitted by Sunday, Monday, then that I would say is like an amazing case scenario.
My target was this week, but let's see.
Try your best.
The midterm is already running fast.
This is like happy relief talk.
Yes,
it's not.
That's why I just wanted to relate it to my term paper. That's
Yeah, and that's a great idea.
Yeah.
So this will help you think through some of your ideas.
Yes.
Don't think of the term paper being the first output and this being the second. Make this the first output in your term paper.
Exactly.
Yeah.
Yes.
Dealing with everything that you feel like you didn't quite get across.
Okay. Right.
Yeah. So the other way around.
Yeah. So you'll just hear from me in a few days.
No, but thank you for volunteering.
No.
It's because we enjoy.
When you send that email, I write like the idea, and I said, okay, why not?
Yeah, 100%.
And it's going to be a non-academic publication.
Absolutely, but people still put it down in their CVs. It showcases the fact that you can talk to the average, because this is part of community outreach. Yeah,
When you said
research
that your
communications.
professor, some would be interested. What do you mean?
You mentioned in the email that maybe you should be a professor. So you have a choice. So what I'm saying is, I mentioned this because sometimes when I send it to professors, they may not have time. But if they know a student is interested in this topic, then you can co-write it. Or if a student has an idea but they don't have enough confidence, I'm not talking about PhD students, I'm talking about master students. They don't have enough confidence. I'm like, okay, collaborate with your professor, write a first draft, get them to fix it, make it a together project. Yeah.
No, I'm pretty much interested, and I don't want to say that I don't have the time, because then it gets in your head that I don't have the time, and it affects you psychologically.
I took out
the
a
fact
few
is
hours.
that
And sometimes you can't do it in one sitting. So for instance, if you decide tomorrow that, okay, you know what, give me 2 hours, let me just put my thoughts down, then you want to revisit it on Saturday and see, does this look all right and sounds all right still? So even when the entity will come back with me with the edits, it'll give me another chance to kind of also review again and see, okay, am I saying this in the right way?
Right.
Yeah.
Okay, thank you so much.
No,
So
you're very, very welcome.
Yeah, how's your PhD going?
How is it going? I have just since my last provision meeting, I have had zero work.
It's like, is it part-time or what?
It's part-time.
And you don't have to travel?
I do. So
Okay,
next time travel is the big E. I travel is the big E. But I have a submission. We have a submission. So because it's entirely research based, our first milestone is a 4,000 word essay that we have to submit.
Okay.
And my deadline is the first week of May.
So no courses?
No courses. You go straight into the research.
And 4 year or 5 year?
So if I was full time, it would be 3 years.
Oh yeah.
Part time is 4 to 6.
Yes. 3 years is like, because if you don't have
3 years is too short.
Too short, but then like we have 2 years.
No, you guys have 4 years.
For 2 years courses.
Oh, you have 2 years. Yes, absolutely. 2-year courses and then 2 years to
practically, like I've just made some draft, but I haven't officially started work on it.
Okay, I see what you mean. But at least you can develop the baseline and all.
Yes. But then these term papers and all,
they're very distracting.
Yeah. I tried to link it to my,
but it doesn't always work.
Doesn't work. And now this semester I'm trying. I told Dr. Riley that I'll write the term papers, then I'll discuss the proposal with you. Let's hope it works.
Is he going to be your supervisor?
Yeah, so far. The thing is that with PhD, like, you have to work independently. You have to learn how to work independently. And then the supervisor tells you, okay, what do you want to do? What do you want to do?
I know. I was going like this. Totally.
How do you want me to help you and all that?
And then the supervisor finally said, okay, you know what, today you seem a little bit more focused. So alhamdulillah, now I can work on the target.
Yes.
It's very difficult.
Anyway, so let's
I'm going to grab some more hot water. It's freezing.
Let's sometime during Ramadan or
highly recommend this. Yes, absolutely. I'm always up for meetups.
Although I plan to be like more focused towards ibadah and all my studies, but let's see.
I know, you have to have some social relief.
Anyway, thank you so much.
Take care, always great to see you.
Yes. Yes. Yes.
Yes, brother.